Hey there, I'm Dr. Race. Did you know that nearly half of all adults over 55 will suffer from sciatica at some point? Yet, most people treat it the same way you would treat a simple headache. You pop a painkiller and hope the burning sensation in your leg disappears on its own. But that quiet assumption is where the real trouble begins.
Here is what nobody tells you. That burning pain radiating down your leg is not a muscle complaint, and slamming your body with painkillers will not fix it. Common anti-inflammatory drugs can increase your risk of severe internal bleeding more than fivefold after the age of 55, silently destroying your stomach lining while the compressed nerve keeps pressing away in the background. Think about a woman named Maria who was 68 years old when a sharp electric pain shot through her right buttock and down her thigh. She assumed it was ordinary muscle fatigue, so she doubled up on forced stretching and took high doses of ibuprofen from her kitchen cabinet every single day. Within 2 weeks, the pain in her leg had worsened dramatically, and Maria ended up in the emergency room, not for her spine, but with severe stomach bleeding and acute kidney failure caused directly by the drugs she trusted. That is the hidden nerve trap. You are treating the symptom while the real problem goes completely untreated, and the medication you rely on is quietly eroding your health from the inside.
By the end of this video, you'll understand exactly what is pressing on your nerve and hold a clinically proven 4-step protocol that you can start using safely at home tonight.
Let me draw your attention to something even more fundamental before we move forward. As you age, your body does not process medications the same way it did 20 years ago. Liver function slows down, kidney filtration drops, and the proteins that carry drugs through your bloodstream decline in concentration. What this means in practical terms is that the medication sitting in your system runs at a higher effective dose than the label suggests, without any adjustment to compensate. If you take a standard dose of ibuprofen at age 70, your body is processing it as if you took significantly more. The older you get, the tighter the margin between relief and harm becomes. And most people never adjust their medication strategy to account for this invisible shift happening inside their body every single day.
So let us break down the 4 families of drugs that are quietly doing the most damage to older adults with sciatica.
First, nonsteroidal anti-inflammatory drugs like ibuprofen and naproxen. These medications block the enzymes that produce inflammation, but they also strip away the protective layer of your stomach lining, which is why 1 in every 175 chronic users ends up in the hospital with a bleeding ulcer each year. Cardiovascularly, they reduce blood flow to your kidneys, raise your blood pressure, and increase the risk of heart attack and stroke. Second, gabapentinoids like gabapentin and pregabalin. These drugs bind to calcium channels in your nervous system and leave you dazed and unsteady on your feet, with nearly 1 in 5 elderly patients reporting serious dizziness that leads directly to falls and hip fractures. Third, opioids such as tramadol and oxycodone. They deliver an average pain reduction of only 7% compared to taking nothing at all, while tripling your risk of mental confusion, deep sedation, and severe constipation. And finally, oral corticosteroids like prednisolone. They offer no proven benefit for sciatica at all, while accelerating bone loss and raising your blood sugar to levels that can destabilize diabetes.
4 distinct drug families, each carrying a heavier toll than most people ever realize.
There is a quieter consequence that most doctors do not mention during a routine prescription, and it deserves your full attention. Large-scale studies have found that people who take gabapentinoids over the long term face a hazard ratio of 1.45 for developing dementia, meaning your risk jumps 45% higher simply from the drugs you are taking for nerve pain. That is not a minor side effect sitting at the bottom of a pharmacy pamphlet. That is a measurable shift in your cognitive future. And here is the part that should catch your attention. These medications offer no statistically significant difference compared to a placebo for acute or chronic sciatica. You are paying with your mental clarity for a benefit that does not even exist in controlled trials. And that is a trade-off worth noticing before you reach for the bottle again.
Now let us pull back and look at what sciatica actually is, because understanding the root cause changes everything about how you treat it.
Sciatica is not a vague back pain label. It is a mechanical problem caused by physical compression or chemical irritation of the nerve roots in your lower spine, running from the lumbar region all the way down to your sacrum. If you're under 50 years old, roughly 95% of sciatica cases come from a disc herniation, where the soft inner gel of a spinal disc pushes through a tear and presses directly on a nerve, but after age 55, the story changes. The most common culprits become spinal canal narrowing from thickened ligaments and bone spurs, degenerative disc breakdown that eliminates shock absorption, and the gradual forward slippage of vertebrae that creates constant shear stress on your nerve roots. There is also piriformis syndrome, where a tight muscle deep in your buttock squeezes the sciatic nerve as it passes through. Every single one of these causes is mechanical, which means the solution has to be mechanical as well, and that is why pills will never address the real problem pressing on your nerve.
Once you grasp that your pain has a physical source, the path to relief becomes dramatically simpler.
Before you start moving, there is one concept that will save you from making your pain worse, and it is called directional preference. The idea was developed by a researcher named McKenzie, and it is built on a simple observation. Your spine responds differently depending on which direction you move it. If you move the right way, pressure shifts away from the compressed nerve, and your pain migrates from your leg back toward your lower spine, which clinicians call centralization. That migration is the single strongest predictor of recovery you can track. But if you move the wrong way, the pain travels further down your leg or into your foot, and that is called peripheralization. It is your body sending a clear warning signal that the nerve is being squeezed harder. The takeaway is simple. Your body already knows the right direction. You just need to learn how to listen to the signals it is sending you every time you move.
Let us walk through the first two exercises of the four-step protocol, starting with the one that requires zero effort from your body.
Exercise 1 is the 90-90 position, a passive spinal decompression technique that works by simply taking gravity off your spine. Lie flat on your back on a firm surface, then rest your legs over a chair, sofa, or stacked pillows so that your hips and knees form 90-degree angles. Place a thin pillow under your head, put your hands on your belly, and breathe slowly and deeply for 10 to 15 minutes. 2 to 3 times per day. Feel your lower back settle into a neutral position as the space between your vertebrae opens up and pressure releases from the inflamed nerve root. Notice how your breathing naturally relaxes the tight muscles along your spine, creating room for the nerve to recover. Exercise 2 is the McKenzie extension, also known as the prone press-up. Start by lying on your stomach. Face turned to one side for 1 to 2 minutes of complete relaxation. Then prop yourself up on your forearms in what we call the Sphinx position, keeping your hips pressed to the floor, and hold for 30 to 60 seconds. If that feels good and your leg pain does not radiate further, advance to the press-up phase. Place your hands under your shoulders, gently lift your torso while keeping your pelvis relaxed. Hold for 1 to 2 seconds and slowly lower back down. Perform 10 slow repetitions every 2 to 3 hours throughout the day. But if you have confirmed spinal stenosis, skip this exercise and use gentle knee to chest flexion instead.
2 simple positions done consistently can shift enough pressure off your nerves to change the entire trajectory of your recovery.
Think of your sciatica like a jammed door hinge. If you keep forcing the door closed with generic stretches, you are only grinding the mechanism further out of alignment. But if you push in the exact right direction, the hinge snaps free and the door swings open smoothly. That is precisely what directional extension does to your spine. It pushes the disc material forward, away from the nerve, and recenters the pain toward your lower back. The remarkable thing is that centralization can happen, even if your lower back temporarily feels more sensitive, because the migration of pain from your leg is the clearest sign that pressure is being released at the source. Most people stop exercising the moment their back feels a twinge, when in fact they should be tracking where the pain is moving, not just how intense it feels in the moment. Keep watching to discover how the next 2 exercises build on this same principle.
Now let us move to exercises 3 and 4, which target the nerve itself and the muscle that often traps it.
Exercise 3 is the seated nerve slider. And it works by making your sciatic nerve glide freely instead of stretching it under tension, which only worsens inflammation. Sit upright in a stable chair with both feet flat on the floor. Slowly extend the knee of your affected leg until it is parallel to the ground. Point your toes upward, and at the same time, tilt your head back toward the ceiling. Then bend your knee back down, lower your foot, and nod your chin toward your chest. Alternate between these two movements in a smooth, rhythmic flow, performing 10 to 15 repetitions 3 to 4 times per day. Never force the range of motion, and stop immediately if you feel sharp tingling or burning. Imagine the nerve flossing itself free from surrounding tissue with every repetition. Exercise 4 is the seated figure 4 stretch for your piriformis muscle. Still sitting upright, lift the ankle of your affected leg and cross it over the opposite knee to form the shape of the number 4. Keep your spine perfectly straight, then hinge forward gently from your hips until you feel a deep stretch in your buttock. Hold for 20 to 30 seconds while breathing calmly. Repeat 3 times on each side, and do this routine twice per day.
Together, these 2 exercises restore nerve mobility and release the muscular compression that keeps your pain locked in place.
There is one more layer you should be aware of before you begin, and that is knowing when sciatica has crossed the line from a manageable mechanical problem into a full neurological emergency. Cauda equina syndrome is the compression of all the nerve roots at the bottom of your spinal column, and it does not announce itself with dramatic symptoms at first. You start with a weaker urinary stream, hesitation when you try to go, or a subtle loss of sensation in your inner thighs and groin. If those early signals are ignored, the condition progresses to complete urinary retention, total loss of feeling in the areas where a riding saddle would rest, and even weakness in both legs that makes walking nearly impossible. The window for complete recovery is within the first 24 to 48 hours of symptom onset. So recognizing those early signs can protect you from permanent damage that no amount of exercise can reverse later.
Let us make sure that this protocol works for your daily life, whether you recover on a firm bed or you need to move through your day safely.
If getting down to the floor feels daunting, you can perform every step of this protocol right on your bed, as long as your mattress is firm enough to keep your spine from sinking. Stack pillows under your legs for the 90-90 position and use the bed surface for prone extensions. When you get out of bed, follow the log roll technique to avoid triggering a flare-up. Bend your knees. Roll your entire body as one unit onto the side opposite your painful leg. Swing your feet off the edge and use your arms and leg muscles to push yourself up to a seated position without twisting your lower back. If you are at work or in public and need a quick decompression, stand with your feet shoulder-width apart, place your palms on your lower back, and gently arch backward for 10 slow repetitions every 2 hours. You can also do discrete nerve gliding at your desk by reducing the ankle range of motion until you find the sweet spot where you feel gentle traction without provoking pain.
Consistency in these exercises, these small daily movements, is what transforms temporary relief into lasting recovery.
If you want to understand why timing matters so much, look at how surgeons classify the final stage of cauda equina syndrome. They call it the white flag stage because at that point the nerves have been compressed long enough to suffer irreversible ischemic damage. Total painless urinary retention sets in. Perineal sensation disappears completely, and both legs lose significant muscle strength. Even if surgery happens immediately after that, the odds of full recovery drop sharply, with permanent incontinence and chronic catheter dependency becoming common outcomes. But the incomplete stage, which happens right before that, carries a high rate of full recovery if you act within the first 2 days. The difference between pressing the right button and missing it entirely is measured in hours, not weeks, and that is why awareness of your own body signals is your strongest protection against irreversible damage.
So let us pull everything together and look at what your path forward should actually look like.
Sciatica after the age of 55 is not a condition that demands stronger drugs or more aggressive treatments. It demands a shift from passive medicine to active mechanical rehabilitation. You now know that non-steroidal anti-inflammatory drugs carry a 5-fold risk of internal bleeding, that gabapentinoids increase your dementia risk by 45%, and that opioids deliver only a 7% improvement over doing nothing at all. You understand that sciatica is a mechanical compression problem with a mechanical solution. You have the 4-step protocol, the 90-90 decompression position, the McKenzie extension, the nerve slider, and the figure 4 piriformis stretch. You know how to track centralization versus peripheralization, and you know the red flags that demand immediate medical attention. The hidden nerve trap is no longer hidden. Your spine has an extraordinary capacity to heal itself when you remove the pressure and give it the right mechanical input. Trust that process and let your body do what it was designed to do.
Start tonight, stay consistent, and let movement do what pills never could.